afternoon, everyone. Good afternoon, everyone. I will be really brief on the moderation. Omar did a great job in the previous presentation. I'm going to introduce you Dr. Dorcray Damatel, founder and CEO of Kuomi. You need to explain about Kuomi and what you do there.
Well, after about 20 years, after about 20 years of working clinically as an ophthalmologist in Germany, and beforehand about 3 years in general surgery, orthopedics, vascular surgery, traumatology.
Thank you.
I decided to go a different way due to the fact because in all these years I've seen the really good, I've seen the bad, and I've seen the really ugly as well in healthcare. So with Kuomi, we're trying basically to go a different approach about including everyone in healthcare and making the healthcare world a little bit more ethical, efficient especially, and profitable in a way that it's not just about money. I mean, we all love money, I love money, Jesus who doesn't? But it's about patient care. It's about finding solutions to give more efficient, better patient care to everyone in any country, really. And it can't be down just to profit taking. So we're going to try and be the connective tissue for the healthcare world.
It was very interesting. Then I will have a question for you with the AI and your work. Then we have Dr. Siddhartha Rajagopal, who's a minimally invasive surgeon. And there is bringing, because he is the founder and CEO of Search Omnic X. So if you could explain us about that.
Thank you. So I'm a minimally invasive surgeon. I've been in the OR for approximately 10 plus years now. And my particular company solves the pain point that every surgeon faces within the OR. So it's working on semi-autonomous capacities of the robot, something which opens up, a lot of questions, I assume. And this particular conference, I think, is a perfect platform to talk about artificial intelligence and the promising future that it holds. Yeah.
Thank you so much. Omar, I don't know if you want to add something to your brilliant previous presentation.
Just to free some time for us in the discussion, I'll keep it brief. But I have just since 1 week launched my own system optimization company called Renova, where we try to implement and integrate everything that I've learned from all the system optimizations, from individual productivity optimization up until the skills of institutions worldwide. So anything in between, wherever I can help, please let me know. Where I also have free templates with the launch of my new website. Please use them with AI integration. I just like to help people. I think that's the final conclusion.
That's true. As you said, sometimes some people forget that we're treating patients. Our managers, sometimes they forget that. So that will be part of the discussion. Also, I want to introduce Dr. Ramon Gutierrez. He's a renowned oncopathologist, and he is the chief scientific officer of the OGRD Alliance in the United States. And especially, he's a specialist in personalized and precision immunotherapy. And also, it was very interesting on the treatment with dendritic cells. So, please.
Yes, thanks, Dr. Francisco. It's a pleasure. Well, this idea started 11 years ago with many blessings with cancer diagnosis of me, large bowel cancer. And my colleague says to me, Dr. Gutierrez, it's not necessary treatment, but when you see in the microscope your biopsy with lymphovascular permeation, you see, I need treatment. But what treatment? There's no for chemotherapy, no radiation, no surgery. I need treatment. And in that year, with the Nobel Prize of Dr. Steinman, I listened something that never listened before in my career with my scholarship about dendritic cells. and I need to make this treatment for me, but there is no moleculars. So I continue work in that, and with the time, I learned to, one thing in the store, one thing is the pizza in the box, and other thing is the pizza, you know? And for this treatment, you need the pizza, and the dendritic cell just only is a store. After that, you have the exosomes, and inside the exosome, you have the phospholipopatomic molecules that really does the work, you know? So from that idea, very innovative, first in class, start with work in OGRD Alliance.
It's very interesting. Well, I'm surrounded today of surgeons. I'm internal medicine specialist, so I would like to say in my hospital I'm the only doctor in the, but it's a joke. What I'm doing on the boundaries of medicine that I'm treating are very related with the statement that the FDA released 3 weeks ago, that they said that after more than 30 years, blaming and labeling the HRT, the hormone replacement therapy, as dangerous, suddenly they removed the black frame from the HRT and become a recommended treatment for all women. So it's a very interesting point on an era of the empowerment of women, that the half of the population, until 3 weeks ago, they had no choice than suffer a lot of symptoms related with menopause. So 3 weeks ago, FDA decided that it was not suddenly a dangerous treatment, and then they said that it was recommended for all women after the menopause. And the second point that I want to bring are the peptides. The peptides probably are the most promising therapy in medicine of longevity. I'm sorry because I don't introduce myself. I'm Francisco Martinez. I'm internal medicine specialist, and I'm focused on longevity since more than 10 years ago, applying HRT for sure. But in the latest years, we have seen that the peptides therapy are very promising and recognized and a safety and useful tool. So we have peptides for everything. We have peptides that can help the recovery of all your patients. We have peptides with us. The famous Ozempic is a peptide by itself. Then it came Mounjaro, and then will come retatrutide next year, hopefully. And they are all safe treatments that will help our practice. So from now, I would say, doctor, your case first, you talk about exosomes. We're talking at the end the same. We are talking about telling the cells how to do the things.
Yes, well, the exosome, many sounds very, very innovation, but maybe not so that, because the regulation currently talk about the exosomes and put the exosomes in a framework of regulatory work similar to the advanced therapies or drug therapies. But you know, when you talk about peptides or you talk about exosomes or molecules inside the exosomes, you're talking about the other kind of therapies. And there is tools for that exactly evaluation, yes. But the regulators apply this new framework to these evaluations? No, because so we suffer the effects of the gap between regulators and between us as a physician, as a prescriptor, as a treatment medicals in front of the patient, because you make a treatment that not proven that this or that agency, but the problem is not the therapy. The problem is the regulator don't use the tool that the other level in this agency approve for this therapy. So the level of disconnection is so big, and what is the problem? Because this bad communication is the factor that delay to more than a generation of patients the benefits of one innovation treatment. This is the problem, because I think that maybe the system, the ecosystem of the treatment and the regulatory agency fit work very good with one innovation in a decade, one innovation in a year. But today, the thing's different. You have many innovations in 1 year, so the agencies is not available to absorb, to assimilate that kind of innovation, you know?
Absolutely agree. And doctor, you told me out there that you are trying to train your surgeons as pilots. Could you explain that?
Yeah. Are you able to hear me? So, as the topic we spoke today is that are we redefining the boundaries of medical treatment? The answer is absolutely yes. So, imagery and diagnostics has a very huge role to play in healthcare. So the technology that I'm talking about is as you're going to help the surgeon identify the structures, it's already in the market. I think it's called the company by name Anot. It's a Japanese technology where the surgeons are able to identify the right planes, the right structures, and it helps the efficiency and the outcome of the minimally invasive surgery done. So my technology is a patent pending one, and since the actual prototype is yet to be developed, unfortunately I cannot reveal more, but honestly, we are there. It's the beginning of something very, very big to come. With the kind of technology that I'm talking about, a surgeon on Earth can operate an astronaut on space. So portions of the surgery where there is pneumosufflation and where there is port entry. I have a background of GI, gastrointestinal and oncosurgery inside the abdomen. And the current leaders in the market are Intuitive, the Da Vinci. I think everybody must have heard of it. And the biggest players, Medtronic, where Johnson & Johnson is also part, they have the Hugo robot. And then a lot of robots, soft tissue robots coming up. So with this technology, I'm thinking of autonomous pneumosufflation and autonomous working port entry. Like imagine any dancer or any artist, if so much of time is being set up on building the stage, wouldn't it be boring? We all want to get to see the actual performance, right? So if we can bypass that time taken for setting up the stage, I think that would be a win for every surgeon. Because trust me, for every surgeon, that was the most boring part. We want to get to the actual surgery, which begins after the ergonomic sweet spot is achieved. Yeah.
I love how you explained. Doctor, we are talking about many things, and everything is possible with AI in the terms of money. Meaning all the things that 5 years ago were costing a fortune, now they are cheaper and more accessible thanks to AI. Is that the base of your project?
It's actually quite the opposite. Kiyomi believes more in the human factor in healthcare. We actually have the opinion that we need more doctors, we need more nurses, we need more anyone in the healthcare business. AI is a great tool. I mean, I'm using it every day. I've gotten so low that I'm using it to write emails to my daughter's school because I can't be asked doing it myself. It's not going to be the savior, not for now anyway. It's being pushed, it's being hyped. I'm sure there's great advances, especially in the robotics part. I think that's amazing, really. I totally agree with that. But we need to train our next generation doctors, nurses, healthcare staff of taking care of patients. We've all forgotten about this. We're doing the job, we're going in into the clinic for 6 to 8 hours a day, counting the minutes down, and then I'm going home. But what happens afterwards? And the demotivation in healthcare or healthcare professionals is actually on a constant rise, especially like in Germany, it's gone to terrible levels. And we haven't quite figured out what it is. I mean, within Kiyomi, we do not use the terminology work-life balance. We actually don't agree with that, and I think it's a pile of rubbish, really. It's just an excuse to not work. We use the terminology efficiency. So we have proved with Kiyomi and with other private practices that we have been advising and collaborating with that we managed to reduce the hourly rate per week, per patient, per doctor and per nurse in surgeries from a 40-hour standard week to about 25 to 30. But we still managed to do the same amount of patients as before with 40 hours with the same quality as well. But that means you've got 2 working legs, you've got your knowledge, you've done the time, you've been in the clinic, you've seen all the pathologies. Act quickly. Don't just, switch on Netflix or do some trading or whatever else. Just do your work. It's quite efficient. So 25 to 30 hours instead of 40 hours a week, same pay, same liberties, everything is the same. You just concentrate the work and the quality is outstandingly good. And also the employee satisfaction, because they get to go home early. They've got other things to do as well. And the patient is happy. He's not going to sit around the waiting room for 2 to 3 hours until some doctor or some nurse finally pulls him out and says, come on, it's your turn now. No, they're done in half an hour to 45 minutes. I think this is what we have to go to. I mean, in our opinion, healthcare is not a service per se. It's a human necessity. It's just like having water or oxygen. So let's go back to that. Now, if you want to be profitable as well, you've reduced your hourly input per week. You have so much more out of it, because how much is 1 hour worth of your life? You know, try and figure that out. If you want to do more patients, stay on, do another 10 hours and do more patients if you want to. But in Germany, we're budgeted. We can't get more money for more patients. We're done. So say in ophthalmology, you see 1,500 cases per 3 months. Once you've filled up that level, anything that comes on top, you work for free. It's nice. So we're trying to change that. We're trying to, you know, motivate and make people more efficient. Just be there.
Will be also a matter of money to pay them better or not?
Well, they're getting for a 30-hour week the same money as for a 40-hour week. They're still having the 30 days of holidays a year. They're getting these bridge days where you've got, like, you know, the Friday is like a bank holiday, or the Thursday is a bank holiday, and then Friday we're closing down. You know, they're getting all the liberties and freedoms in the world, but when it comes down to working, in their actual working time, they are there physically and mentally. And there's one thing that is really important, is the first contact that a patient has is with the nursing staff. It's with the receptionist, right? Now, if that man or woman has a really bad field day, that patient is out. He's going to destroy your day. He's going to be coming to you as head of the department, and he's going to tell you, this was horrible, blah, 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 and you're going to get a lovely Google review. Well, we don't want that. Have a smile, have a happy day, come on in, make the patient feel safe.
Thank you for your answer. And doctor, you mentioned something very interesting at the beginning. Our practice is really, really forward compared with our regulation. Could you develop that, please, and explain?
Well, my practice last year is more than I can explain but it's not because I find this practice, because the instant, the circumstances moved me. I am pathologist. Many years ago, I read biopsies on the microscope, but after that, I need to move to the cell therapy, you know, and in cell therapy, you see in the patients very good benefit that you can get with other therapies. So you know that you continue, but if you continue in that treatments, you are the target for many critics, even for the friendly colleagues, you know. But when I stay in that decision, my father suffered a terminal cancer, diagnosis with 31 metastases. And my colleagues, my oncologist says, you know, Ramon, just few days, no weeks, no months. And my father says to me, son, not like that. Give me just a little time that you can. And I returned to these protocols and the therapy for that. And this week and these days, finally was 3 years. 3 Christmas, 3 birthdays, 2 American Cups of Soccer that never expected about that, and I can see in the real world the concept of dissociation, of disconnection. 11 years after, we treat 3,500 patients across 11 years, 24,000 applications. With a very real-world data, with many cohorts, subgroups, under IM resist parameters, some agency like FDA, this is a new therapy, and you can approve maybe this therapy from under the new approach methodology, but this name is not exist. So if you wish escalate and get approval for this therapy, you need make a new name, new approach methodology, new protocol. So you can enter to the castle, but you need your own bridge, you know? Make your bridge. For that reason, in our company, when we have already the treatment, the protocols, the results across the years, we put our efforts in made a new name, a new approach methodology protocol. We are ready, things, really we are ready, or this our idea, just that. So we contact some agencies and consulting firms about a pre-FDA evaluation, and you know what happened. No, this is no exist. You are mistaken. You are wrong. And the number 20X, very interesting. Let's with that. And we get two consulting firms, very famous, Fryer and Beristat. And after 2 years, we approve this process about pre-FDA. So we are ready to pre-IND FDA. Wow, where are you now? But no many peoples, no many patients, not all patients can get a treatment like that. But many patients need some structural immunotherapy for support, even for prevent purpose, you know. And in that, for that reason, we made the 4 immunoceutical line like a spin-off, because we cannot treat this patient with therapy derived from secretome of the dendritic cell, but maybe we can find other way. What? Phytochemic-based phospholipoproteamic complex. And we have 4 lines. And the backbone regulatory, STIP. So this STIP is audited for a consulting firm pre-FDA, and we have 3 papers Q1 published about the STIP. So the STIP is not our idea, it's a real concept, very strong. So we have many work in the next year. Also, we have good, very investors in this project, but one thing goes to you, the other thing. So what we do tomorrow or the next year, well, I don't know, but the things move it for alone, you know. the things goes on, and we follow the circumstances.
Thank you so much. Doctor, I was asking you about the AI before, because in longevity world, it's making the game changer, and it's making it accessible for a lot of people. So that was the reason. On my field, longevity, AI has been a really tremendous change on the attention, because it's a very personalized medicine. Every patient is aging in a different way. Every patient is a challenge. So HRT, even HRT for every woman or for every man, it's completely different. And on the medical field, for the internal medicine, it's something that has to help us on the chance to attend our patients as they deserve. So that was my point. And one more question, and that's curiosity. When will be your tool available? Because this thing of operating people in the space was amazing.
To give an honest answer, it does seem like a fantasy, but we need to have an exit strategy. And at present, we are a 2-member company. My collaborator, who's also co-funded and founding this company, is a colorectal surgeon. He's a program director of Mexico General Hospital. And to add on to what I said previously, and Dr. Ramon, so he says that oncopathology is the kind of the future. And I do agree that in precision medicine, we'll have to go at the cellular stage. And the spectrum of visibility in surgical area, the focus is also on NIRF, called near infrared fluorescence. So we give a particular chemical inside the body, and a particular organ lights up. So even in colorectal surgeries, and to identify the ureters and to test the integrity of the colorectal anastomosis, we give this chemical called indocyanin green. And within a matter of 5 to 10 minutes, the sites of anastomosis lights up to see the actual blood supply. So you can test the integrity of the anastomosis on live, on real-time basis. So on a real-time basis, with the advancements that AI can provide to the surgeon, like the third eye, in the Hindu mythology, there is this popular character called the Shiva, where he has his third eye on his forehead. So I think a lot of answers we will be getting if we are able to see the unknown. But to see the unknown, we need a newer technology, which AI can provide. And I think a strong answer lies in pathology. And, the tissues will speak a lot to the surgeon.
Yeah. I would like to tap on that because a couple of months ago, the inventor of the fluorescein technique is Dr. Suhail, which is with us in Harvard in Boston. He actually invented that by sitting on a bed, looking at the glow-in-the-dark stars of his daughter in the room. And that way he came up with an idea like, I need to see what I can't see. So what he does, he allocates a different technique from somewhere else, let's say, for instance, AI, and he sees a gap that is filled with that, which is exactly the coordination which you are saying and talking about, Siddharth, seeing with the third eye what is out there. And a huge pitfall now is that a lot of people are using AI blindly and just throwing AI at anything they can actually see without seeing. And then with that, you get very bad results. What we see is a saturation in the market with a lot of unusable AI outcomes. And at this point, everyone is ignoring it. But just like we were throwing garbage out in space earlier and making plastic, this will come back and circle back as a problem in the future, where just to tell anyone, we need to find the right place, the right gaps, and therefore resources to be put in the right allocation to have AI help us. Use it as the weapon in the coordination instead of hurting ourselves now with AI.
I agree totally. AI, you need to know what are you going to ask, and then you need to process the answers. Cannot be the dogma. I agree totally with you. So thank you very much. Our time is over. Thank you very much. I learned a lot, and I hope to be in contact with you. Of course, if anyone has a question, be my guest.
Question there? Is there a microphone for Sir in the back? Thank you.
Thank you for this great discussion about AI, and there are a number of issues of its misuse and causing more chaos in the field than actually advancing it. One of the issues with AI in health, unlike in writing your essays in college with ChatGPT or whatever, is the issue of liability. Health is human life and death situations. You cannot use it. Now, the question is, how do you make it reliable? And because it's a powerful tool. And I would invite you to come to my talk tomorrow. I'm giving a keynote address of the first application of reliable AI. Okay, but it's very use case specific. There's no AGI. I jokingly say AI ain't intelligent, but at the same time, you can make it intelligent. Now, I think what I'm trying to say is we are in this transition phase of trying to bring a powerful tool that'll change medicine forever. And my question to you is, besides our approach, what do you think needs to be done at the clinical data collection level to make that reliable? Because if you make that reliable, the algorithm will be reliable, and you won't get GIGO, which is garbage in, garbage out, right? So my question to you as clinicians, what else can you do?
I would like to answer that.
Please do.
There's a couple of things.
Yeah.
First of all, standardization, I think, is the most important of all. AI is very good, and machine learning overall is very good in pattern recognition. So if you standardize your systems in a way that it is learned and taught to an AI, it can actually leverage and tap into the full potential and capacity of an AI. Just the same with humans. If we use it in the same right way, we can ourselves use our capacity for different things. Then the second thing is regulations. Having the right types of borders and boundaries of which a system should know this is not for me to trespass, and at the same time not confabulate, assume anything. So it takes someone like an architect or someone that understands how the prompting, the learning, the algorithm is to actually leverage and tap into it. With institutionalized control, like the arenas that we now have with different kinds of AI, I think this is a governmental, global kind of issue where we should also step up together as clinicians, care providers, to see how we should pull this card and see where we should use it and where we shouldn't use it. Or else, of course, as anything, we might get hurt.
If I may just say something, so what is going to be a gold standard to which you will measure the outcomes from any AI application that is trusted by the practitioners of medicine? Because you are ultimately, when we come to the hospital, the doctors are the gold standard. You have a lot of things that are accepted standard of practice, right? So what would be the orthogonal way to take this new language and map it to a gold standard, an orthogonal validation that is acceptable? And I'm a little bit not quite sure what that would be in clinical practice.
I think the golden standard should be aligned from what we see and is done overall as a norm by other clinicians. So it's surveys, standardizing, what is the overall framework, having that institutionalized, aligned what everyone does together. We can collaborate in even having shared data banks, using algorithms on that, providing way more synergistic answers than we could ever do alone on our island. And then from then on, we create our golden standard, not by ourselves, but together by having the system set. Now, of course, this is a very ideal world, and we have different cultures, as we spoke about earlier. There's a lot of politics going on, but this is exactly where I think people that are currently bridging should step up in these times to actually help with making that kind of collaboration possible to create a golden standard and provide the best care.
We can.
Yes,
So
we can.
Come tomorrow to my talk, and I'd be happy to help. I wanted to advance. We have some success, and we would like to build that out, working with the clinicians and the clinical practices to make that broadly applicable. So thank you for the great panel.
Thank you for your input.
I'd just like to supplement.
Yeah, please.
Am I audible? Great points by Dr. Omar. I'd just like to supplement a few points. So you asked about which is going to be the gold standard. I feel that would depend on the clinical outcomes. Whichever amongst the trials or amongst the research that we conduct has the highest efficiency of the clinical outcomes, that is going to be the gold standard. And it goes without saying that efficiency, like even in the basic physics, you throw a ball at the 45-degree angle, that's when you have the maximum range. So you can try all the angles, but it's only the 45-degree angle which will give you the maximum efficiency. So I think in that, we could probably record all the data, we could compare all the results, and the most efficient one is going to be the gold standard. And when it comes to increasing the efficiency of the process of conducting research, I love this Japanese philosophy once again called Kaizen, where every step is divided into many micro steps. So we need to have a lot of checkpoints, multiple checkpoints, and multiple thumb rules at every level, a fail-safe mechanism, where there is no point, and forcing functions, where there is no possibility to do any sort of an error. And in that way, we can increase the efficiency of AI, and we can increase the reliability of AI in healthcare. Yeah.
All right, thank you so much. We'll have the last question. All right, yeah.
Thank you so much. This was really enlightening. And sitting on the other side as a technology specialist, hearing from some of you leaders on the doctor side and the clinical side. So I'll piggyback on the question, the same question. Currently, if you look at patient timeline data, there are a lot of data missing. There are a lot of data when they are not interacting with the healthcare service or healthcare system. There's a lot of data missing. And we all know that AI can function well with a robust amount of data. Now, as clinicians who are sitting there and doing this, what do you suggest? Like, we all know that AI is going to be, or in the future, going to be one of the important tools to make, to take the healthcare forward. So what are the things as clinicians, as doctors, you guys are looking at on some of this missing data, and how do we solve for that problem to ensure that our AI and these tools work far more seamlessly in the future?
I think that is a problem that we doctors as a fraternity face together. It would start at the very basic level where every doctor should be comfortable with exploring the unknown. And if they are genuinely interested to contribute to a new technology and to adopt a newer technology, the willingness to impart and record data, I think that will probably increase the efficiency of the system and maybe to lead to lesser errors.
Sorry, I'm just going to add on quickly, so I know we all want to go and have dinner or something. The problem that I see with AI, I mean, we at QME, we're not against AI, don't get me wrong, we totally love the systems. It's just like they have not reached the point that we can rely upon them. Because if we were at that point that we can say it's safe to use AI, we're using it in ophthalmology, we use it in ocular coherence tomography, in fluorescence angiography, and it's like, pattern-based, as you said before. It looks at a picture, it tells me, okay, there's a leakage, you have to do this and this and this. Great. So that's one aspect, but the sensitivity is not there yet. So if it was, how many clinicians are in this room right now? Just quickly, hands up. Okay, so it's two more. Okay, so 50% of you two could just leave because we have AI doing your job. I mean, this would be ideal, wouldn't it? I mean, the thing is, I like AI and I'm going to use it myself, but it has to be efficient and it has to be specific. Now, who controls it? This is my question. I mean, we have ChatGPT being controlled by one guy, we have Grok being controlled by Musk, and we have Gemini being controlled by, what is it, Samsung? I have no idea. I don't know. So who writes the prompts, who writes the code is in control of the AI and can control medical outcomes. And I find this, personally, I find it quite scary. I'd rather rely on a colleague with 30 years of experience to tell me what to do and how to go about it. It's a totally different thing on robotics. Robotics is a completely different matter, but AI is very difficult.
Just to close it off on a positive note, this is exactly what I meant. The persons, I think it's great that you see it like this and are aware of the cautiousness and the danger, but we also have like different templates, usable skills, just like you said. I agree, there's no shortcut for hard work, but we can actually have this pretty easily learned how to use the right prompt to get the right result, even for someone without the knowledge. And that is where eventually we ourselves get to free our capacity to do the hard work that we can't replace. So it is dangerous, but if you're cautious and aware, please use it in a safe way. please reach out to me in any way. I'm always happy to help.
I will. I will actually reach out.
Thank you all for your attention.